joining us for the OHA COVID-19 webinar series for healthcare providers. This is Ariel Smits. I'm the Medical Director for the Health Evidence Review Commission at the Oregon Health Authority. And with me today is Tom Jean, tell me your title again. You're the
Deputy State Health Officer, Deputy State Epidemiologist, and one of the Senior Health Advisors for the COVID-19 response.
Great, thank you. And unfortunately for her, Dana Harganani is on vacation this week, so she won't be joining us.
Much deserved.
Definitely. So we'll try to hold on the fort for her. So today on our agenda, we'll do our usual situational updates. We have a couple of OHA guideline updates to bring you, and as well as a national guideline update. There's literature updates, although actually some of those I mixed in with some other interesting information that you asked us to follow up on with school information. So you'll get some literature updates throughout the presentation. And then hopefully we'll have answered most of the questions we didn't get to last week through the rest of the presentation. But as usual, if you have questions, please put them in the chat box and we will try to answer them periodically during the presentation or at the end as we are able. And Dr. Jean, do you want to walk us through the situation update?
Yes, thank you. So here is our typical situation update starting with our epi curve. And this is our latest numbers as of yesterday. We had 18,936 total cases in Oregon. That's cumulative cases from the start of the pandemic. And 1,726 hospitalized cases, again, cumulative, and a total of 338 deaths to date. You can have a look there at our curve. It's actually looking okay. We're not seeing, a steep rise, at least not as steep as we were seeing in late May and June. Of course, the final curve, it's only really accurate up to about 7 to 10 days ago, just due to cases that are reported late and keep coming in. So somewhat encouraging to see that. Next slide. So for the most recent week for which we have data, we tested 35,000 people in Oregon and identified about 2,200 new cases. We did see an uptick in our percentage of positive tests. Actually up to 6.1%. Last week, as you recall, we saw a decline, the first decline in a couple of months. Well, it's back up, and it's one of the highest percentages we've had. However, you will note that the number of tests performed went down a bit. So it's possible that a fewer number of people with mild symptoms or without symptoms were tested, and that would be one reason that the percentage of positive would go up. Next slide. One of our metrics, this is a slightly different one than we've shown in the past. This is a metric showing new cases with and without a known source. So when cases are identified and case investigation and contact tracing is done, we see whether a new case is linked to a previously known case. And the orange are those that are traced to a known source. That could be an outbreak or it could be another person that we already knew about. And then the blue are those that are not traced to a known source. The black line is a moving 7-day average of the number of cases without a known source. So it has been creeping upward for a while now, just representing increased overall high levels of community transmission. Another metric is our active monitoring capacity. This is also a slightly different one than I've shown from our previous webinars. There are a bunch of these metrics, again, on our website, healthoregon.org/coronavirus under the data dashboard. So I encourage you to have a look at those. The main things to point out here are the orange and gray bars, which show where we're not meeting our goal of 24 hours or less between the report of a case, a lab report usually, and the time before public health or tribal health was able to begin follow-up. Again, showing the strain of cases right now. This is a new slide. This is from a relatively recent report on pediatric cases specifically. And I'm just going to highlight that this is showing the number of cases for children or people under the age of 18, with a pretty significant increase here in June and July. And you'll notice that back in March, when we had the first wave in Oregon, there was not a lot of pediatric cases reported, probably due to limited testing and limited awareness and things like that. But we are seeing a significant number now. And of course, there's more information in this report that I'm not going to highlight, but they are in general having milder illness and fewer hospitalizations than adults. So this is the link I mentioned, just our main page. Towards the top, we have our data dashboards, and this has been rearranged recently. There's quite a bit of information there, so please have a look.
Yeah, this is a really nice data dashboard. I use it quite a bit, so I definitely recommend that you play around with it.
And on that note, we now have, I think this is just in the past couple days, we've got a more interactive site here now for COVID and hospital capacity that has both statewide and regional trends. So this is the statewide trend, which is what we've been showing you for a while in all COVID positive patients in the top line, ICU beds in the middle line, and then COVID positive patients on ventilators in the bottom line. So this is the census, so the current estimate of COVID positive patients in those categories. So it's been actually pretty stable for the past few weeks here. Next slide. So this is one of the new graphs. This is showing by region, and there's a map of regions on the website. Region 1, as you could probably guess, is the Portland metro area. And with the two different colors there, you can see the occupied and available ICU beds in blue, and occupied and available non-ICU adult hospital beds in orange and red by region. So most regions showing some still a buffer of capacity at this point. Yeah, let's move on to these guidance updates. I'm going to briefly mention one, and then I think Dr. Smith will do the second one. So I just wanted to highlight that we had an update to our Remdesivir treatment guidance. I think it was a pretty minor update. I was not involved in it, but the main difference that I see is updated NIH treatment guidelines for COVID in there. So you can have a look at that. It's a pretty short document. And I will say that we are still distributing Remdesivir to hospitals, and that's just kind of on a request basis through our emergency operations center. So hospitals can go through their usual channels to access Remdesivir.
And I wanted to just bring you up to date on, for those of you who take care of Oregon Health Plan patients, which is Oregon Medicaid, I just wanted to just bring you up to date on a few changes to the prioritized list. The prioritized list is the document that sort of lays out what the coverage is for OHP. I wanted to bring you all attention. There is a new CPT code for SARS-CoV-2 antigen testing. This is effective as of, I believe, July 30th. So just to make sure that your systems have that open. That's for diagnostic testing of tests that look for the antigen but don't use PCR. And then this new prioritized list that will be published on August 14th will contain a new diagnostic guideline. So you may get some feedback from your local CCO or something if you try to order something that doesn't go along. But basically what it says is that testing for the actual infection, either with viral RNA test, PCR tests, or viral antigen, is a covered diagnostic service. So you shouldn't have problems with that. But antibody testing, which is looking for someone's antibodies for past infection, will only be covered if you use a test that has FDA emergency use authorization, and it's used as part of the workup for multisystem inflammatory syndrome in children, for those kiddos hospitalized under the age of 21. So that will go into effect in about a week, as long as the HERC meeting next week approves all these changes.
So this is in response to I think a question that we got from last week. The question was asking about the recent update that came towards the end of July to CDC's guidance on the duration of isolation. And I think we had mentioned a little bit about that a couple weeks back. But But the question was specifically what evidence or what was the rationale for CDC's change, specifically from the 72 hours after fever resolves to the current 24 hours after fever resolves. So just as a reminder, the current duration of isolation and release from isolation guidance is that isolation, so that can be home isolation for somebody who's at home, or isolation precautions, transmission-based precautions for somebody in a hospital, can generally be discontinued 10 days after symptom onset, and at least 24 hours after resolution of fever, so whichever of those is later, without the use of fever-reducing medications, and other symptoms need to be showing improvement. So the CDC has a decision memo on their site that kind of highlights the current evidence on this, and it really comes down to, first of all, we know that concentrations of the RNA of the virus measured in the upper respiratory tract decline after the onset of symptoms, and also the likelihood that you can actually recover replication competent virus declines, and there's multiple citations for both of those. And then for patients who have mild to moderate COVID-19, there has not been any solid evidence that transmission or replication competent virus is happening more than 10 days after symptom onset. Except in some people, so people with more severe illness, especially those with the immunocompromise, it has been seen after 10 days, but generally less than 20 days. And there was a series of patients there that showed that even in those immunocompromised or more severely ill patients, 88% of the specimens no longer had replication competent virus after 10 days, and 95% no longer had it after 15 days after symptom onset. And then they also cite a large contact tracing study showing that high-risk household and hospital contacts did not develop infection if their exposure to a case patient started 6 days or more after the case patient's illness onset. So these are kind of the reasons for the 10 days and the 20 days. And I think because that evidence is so strong, the CDC probably opted to go back to the more traditional 24 hours after fever. That's kind of a more standard public health recommendation, rather than the 72 hours, which I think early on in the pandemic for this new novel virus was done out of an abundance of caution. So I haven't seen any specific reason that other than that they would go back to 24. But this is the evidence. So if you go to that link there, you can see more of their rationale, and you can look at the citations of the papers that formed that decision. Hope that answers your question.
All right, and we had a nice presentation about school metrics at our last webinar, and there were a lot of questions about that, particularly what was the data behind the school metrics, why were certain numbers picked, etc., and some questions about transmission in children. So I wanted to bring you some information about that. I'm going to start out by just, we did at our last session talk about a couple of studies. One in Korea showing that particularly older children seem to transmit viruses as well as adults. So that we've already looked at those studies. These are a couple of newer studies that have just been published. There was one in this week's JAMA Pediatrics, which was looking at a cohort of all persons that were tested for SARS-CoV-2 at various sites in Chicago. So these could be outpatient, inpatient, ER, whatever. They had a cohort of 145 patients with mild to moderate illness who had tests within 1 week of symptom onset. And then they grouped them by age into young kids under 5, kids ages 5 to 17, and then adults. And they found similar cycle time values for older children and adults. For those of you who aren't familiar with cycle time, the lower the cycle time, the higher the amount of viral RNA. So cycle time is kind of a proxy for density of virus. It might be a way of thinking about
Viral load, yeah.
Viral load. But the young children, those under 5, actually had a significantly lower cycle time. Basically, the conclusion being that young children have at least as much, if not more, viral load in their upper respiratory tract as older children and adults. In fact, they had 10-fold to 100-fold more viral load. So maybe not proof that it's actually infectious, but it definitely shows that they have viral load. The second study is much more kind of going toward evidence of infectiveness. This was the MMWR that came out last week. I mean, you've probably seen this in the press. This is a summer camp, an overnight camp in Georgia. And for a few days, they had 138 trainees and 120 staff come to camp. Of note, they all had negative SARS-CoV-2 tests prior to arrival. And then after a 3-day orientation, 363 campers and 3 senior staff came to camp. The camp followed the CDC guidance on infection control. Campers were cohorted, staff all wore masks. The children, however, did not wear masks. That was very important. On June 23, a counselor became ill and was sent home. He had a positive COVID-19 test on June 24, and the campers were all sent home over the next couple of days. The Georgia Department of Health followed up on all the campers and staff that they could find, which ended up being 344 of the attendees, about 58%. The others probably went out of state and weren't available to the Georgia Department of Health. Of the tests that were done in Georgia, 76% were positive, so a really high rate of infection. And it was about 50% in those ages 6 to 10, and then a little bit lower in those 11 to 17, and even a little bit lower among the older folks. About a quarter didn't have any symptoms. They were just tested as part of contact tracing, and about 3/4 had symptoms, usually fever, headache, or sore throat. So basically the conclusion in this is that yes, children and young adults can spread this, and particularly for overnight camps, this appears to be a very good way to get infection. There's a couple of notes to this study. There was a lot of singing and shouting and chanting, and the children weren't wearing masks, and this was an overnight camp where people were in cabins together. They noted that in a cabin with A positive, the majority of people in the cabin were positive. So probably a good portion of this may have been due to the sleeping arrangements, possibly. But again, this is evidence leaning toward the fact that children can transmit. So the next slide is, what do studies show about reopening schools? And I have to give credit to my colleague Ann Thomas. The next couple of slides came from her. So we've looked at the data that show that kids can definitely be infected with this and can definitely be a source of infection for others. And then there's also studies that have summarized that closing schools has been related to decreasing the spread in COVID-19 in communities. We reviewed one of these in our last session that was a study, kind of a community ecological study showing that school closures were independently associated with lower COVID transmission. There are also other things that make a big difference, including wearing face coverings, hand washing, physical distancing, etc. What Oregon modeled was that if we reopened schools and didn't take any other prevention measures, the rate of COVID-19 would double in the first 3 months of school. If we use all the other things that have been in the school guidance, like face coverings, hand washing, physical distancing, etc., we can work toward making schools safe. But this gives you a little bit of the background about one of the reasons why there was a lot of, the governor wanted to put some bumpers around when school could open in person. So this is just to remind you what we discussed briefly last week. Schools are safe, can reopen to in-person instruction when the county has less than 10 cases per 100,000 for 3 weeks in a row, and that test positivity is less than 5%. So basically, these are the two different ways of looking at infectivity. So we want not very many cases, and we also want there to be the testing showing that we're not missing a lot of cases. So if your test positivity was like 10%, then we know that we're not testing enough and we're missing cases. We also need the statewide positivity to be less than 5%. So this is the what the governor has set as the reopening criteria for in-person schools. And then this is the slide that I really wanted to show you about a lot of the rationale for why the governor picked all of these numbers. So these are various countries and when they reopened schools and at what their rate of infection per 100,000 was. As you can see, every country other than Denmark was below that 10,000 per 10 per 100,000 level, and they were able to safely reopen schools. And you can see that Oregon definitely was in that range in May. Unfortunately, we are not in July. Hopefully, with mask wearing and other policies and other behaviors going into effect, we can bring that number down. But this gives you a sense of where that number came from. And then I just wanted to point out, this is on that website that Dr. Jean showed you. And we have now started to post case rates per 100,000. For a long time, it was not posted precisely in that way, so it was a little bit confusing, but now we do. So this is from the last couple of weeks. You can see that our case rates in Oregon are definitely above 10 per 100,000, and our test positivity rate is also above 5%. So we're not getting close to having schools open in person, unfortunately. So COVID literature updates. I did sneak a few in about the kids and infection. There was one other study that I wanted to just bring your attention to because I thought it had some interesting points. This was in this week's JAMA. It was looking at disparities, mainly looking at white infections and death versus people of color. And they were really trying to look at the hypothesis that perhaps it was the living environment. You know, people who of color are more likely than white people to live in lower income areas. They may have less access to healthy foods, safe recreational areas, etc. So they actually did. This is again an ecological study. They're looking at sort of national data on median income as well as national data on infections. So they defined a less poverty county as having a median income of about $80,000 a year, and a more poverty county as having about $60,000 for their median income. In the more poverty counties, there was substantially more non-white populations that had an infection rate. It was nearly 8 times that of counties with a substantially white population, and their death rate was higher. So that was then the more poverty counties, definitely the people of color had a much higher impact. But they also found that in less poverty counties, there was still substantially more infections and deaths in those people who identified as not white. So there's definitely more going on here that we need to look at and we need to be aware of. So and basically it's not just income, it's not just where these folks are living, but there is more there. Just to be aware of that when you are thinking about, you know, people who are coming into your office, to be just a little bit heightened when you have a person of color, to you know, possibly test them and be a little more aware. So we answered all of your clinical care questions during the last webinar or during the beginning of this one. So I'm going to switch over now to the questions that are coming into the chat box, and I'm going to put Dr. Jean on the spot. There was a question about ability to test, quickly test cohorts now that schools are opened, and how are the counties doing on that ability?
The ability to quickly test cohorts. So, you know, when we have the cohorts definition that's coming out in the new school reopening guidance, there's been multiple versions already, and there's a new revision coming next week. You know, cohorts are really designed to, number one, limit the exposure of students and staff to others, but also to make it easier to do the contact tracing. So that's one of the main goals. I know there are some summer schools in session and some limited stuff happening, including in person, but I don't have any specific information about what we've done so far, like how our contact tracing or other public health efforts have fared in school settings versus others. But I have not heard of a lot of, you know, major school outbreaks at this point.
There was a question about case rates per 100,000 versus 10,000 on our data dashboards. I think, haven't we just started to publish it as per 100,000?
Yeah, I believe.
Public feedback.
Yeah, I believe we're just trying to align with what most people are reporting them as. And it's, it's pretty simple. It's just a factor of 10. So if you take the rate per 100,000, you just multiply that or divide that by 10 to get the rate per 10,000. But we do want to make it very simple, and so people don't have to do that math in their head to compare.
And if you go on the screen right now is Dr. Jean had shown the new data dashboard. If you go to I believe it's the weekly report. One of these reports will take you exactly to the rate per 100,000, so that if you want to get a sense of how your county is doing, it's pretty easily accessible.
Right, and then if you click that bottom blue box is now is the school metrics, and that has the rate per 100,000 in it. But I believe unfortunately, some of our metrics are still per 10,000. So that's something that we can work on.
Yeah, and just make sure you look at the denominator. I mean, it is just adding zeros or taking, but just be aware of that so that you don't quickly look at something and get confused about the numbers. There were some questions about the camper study. I believe all staff and all campers were tested ahead of time. There was no data that the CDC or the report had about how soon before camp or how that was verified, etc. So, they were supposed to have evidence so that they've had a test within a certain time period. We don't have that data, wasn't published, so we don't have a strict sense of the numbers. And then there was another comment that this might relate more to household spread because of the cabin situation. I know that there have actually been multiple day camp outbreaks, and in fact, right now, if you look on our outbreak page on the OHA website, there is a day camp in Multnomah County that has a current outbreak. So it's not just the sleeping situation; it's some portion of the gathering of people situation as well. There was a request for the new isolation recommendations to be put in the chat box. We can, if you go to our website, there is a isolation, the isolation and quarantine recommendations are in there. And we can, on our next webinar, maybe put that link in our presentation. It may have actually been in last week's presentation, but play around on our website and you will find it. There was questions about you can't see other people's questions in our chat box. I'm sorry about that. We are dealing with the technology that we have and trying to do our best. So
thanks for the feedback, pal. We'll see what we can do on that. It would be nice.
Yeah, then there was a question, it was more of a reminder to you all folks that to make sure with that study that I had kind of talked about people of color having higher rates of infection and higher deaths, just reiterating that migrant and seasonal farm workers, Native Americans, and then other folks, people living in congregate care settings, etc. You need to think about screening them and their contacts a little lower threshold because of the need for perhaps more protection intervention in those communities. So thank you for that reminder. Are these slides available for download? Yes, these slides all are on our website. If you go to the provider page and you go to webinar, you'll see all of our previous presentations. They're all available there, as well as I believe the Project Echo slides are available for.
I think those are on the OHSU Project Echo website. And Dr. Smith, if you're in the chat box there, you can type in this link for people to get directly to the clinical care guidance, which has the release from isolation. It's healthoregon.org/HCP COVID-19.
HCP COVID-19, all one word.
Yeah. And that's kind of a shortcut link, and that'll take you right to our clinical care and healthcare infection prevention and control guidance. And let me figure out the page there that this appears on. This is specific for healthcare workers, but it has the same language about discontinuing transmission-based precautions or discontinuing isolation. And that's on page 5. This is the symptom-based strategy broken down into patients with mild to moderate illness and patients with severe to critical illness or who are severely immunocompromised. And the difference is 10 days versus 20 days after symptom onset.
Where do we see outbreaks? So they're on the OHA website again. On the weekly, if you look at what's on the site right now, the sort of the second blue box weekly COVID-19 report, if you scroll through that, it's way down toward the bottom, but there's worksite outbreaks, and then there's congregate care outbreaks, and then at the very bottom, there are 2 camper educational outbreaks current. So you can look, and it's only for places where there's more than 5 confirmed cases. So, if there's an outbreak of 2, we felt that was too identifiable. And it will list the location, the county, the number of people.
And for most of those settings, like the businesses, I believe the business has to have more than 30 employees, or the congregate care setting would have to have more than 30 residents and staff before they could meet that threshold. So 5 cases and at least 30 people total.
And there was another comment about our 10,000 per 100,000. Someone said the numbers look very similar. Thanks for that feedback. We will take a look and make sure that we are posting the correct numbers. Let's see. Why do you think everyone is so reluctant to consider the possibility of varying genetic susceptibility among different ethnicities? I don't think that that's the case. I think people have, we've known, like, for example, African-American men have higher risks of hypertension. Native Americans have a higher risk of diabetes. Whether that's diet or other lifestyle or genetic, those are so hard to piece apart.
Yeah, I guess I would say that there certainly are different genetic predispositions that vary from racial group to racial group and ethnic group to ethnic group. However, I think that question can often be a real distraction from the structural inequities that we know are the driving cause of health inequities. And so I think it's appropriate that there's less emphasis on that, and trying to tease that out can be a lot of work anyway. And even then, you're just making generalizations as opposed to looking at an individual patient. So when we're talking about populations and disadvantaged groups, various groups broken out by those demographic factors, I really think that the environment is what we need to be focusing on. It's what we can change. We can't change our genetics.
There's a question about face shields, that face shields have been recommended interchangeably with face masks, but the evidence is lacking. And they wanted to know if this is being reevaluated.
Yeah, we, the senior health advisors here at OHA have recently decided to revise our position on face shields. We are now emphasizing that face coverings, including face masks, are preferred. And I think the main reason is that face shields offer a lot of protection from droplets, but they don't offer the same protection against aerosols and perhaps some of the smaller droplets. So there are some exceptions where we would say face shields are okay, and that would be places where, for example, in schools where there's a real need for younger students to see a teacher's lips, for example, or speech language pathology. So there are some limited settings where we would say it's okay, but in general, we are recommending face coverings, cloth face coverings, or masks.
What is Oregon's stance on the use of rapid, less expensive antigen tests as a strategy to detect those who are infectious?
Yep, so this is a really important question that's been getting a lot of attention nationally. Antigen tests, currently there are only 2 that have FDA emergency use authorization, and we've been receiving reports from around the country of some major concerns with one of them in terms of having a lot of false positives. False positives are a real problem for any kind of test, especially if you're going to be screening people. So we're trying to evaluate that and get some more hard data before we have a verdict on that. I'm also not sure how much of these are available yet. In general, I think there is going to be a real place for rapid testing, especially if it's more readily available, easy to do, perhaps saliva based, like some of these antigen tests. And so even though they may not have the sensitivity of PCR, we'll continue to look at the data and try to get them out, try to see if there's a way to implement them in our testing strategy, so that we can get testing out to more people that's actually useful.
Great. Now that money is being distributed to the CBOs, which are the new community-based organizations, will there be evaluations to identify best practices and accomplishments and lessons learned? That's a good question. I personally am not familiar with how they're structuring the CBOs. I know a lot of the work with them is to get culturally and linguistically appropriate contact tracing and other services out to different groups. I can't answer the question about evaluations.
Yeah, a couple of our other senior health advisors have been more involved with community partners and CBOs, so we can try to address this question next week. Get back to you.
Since you mentioned aerosol transmission and face shields, is OHA doing independent evaluation of possible aerosol transmission and the need to protect against that?
Well, it depends on how you define independent. We are independently reviewing the evidence. We don't have the resources or to do our own studies. But there is, this is a global pandemic, and there's lots of research and reports coming on the efficacy, as well as the dynamics of transmission. And we actually have been lucky enough to work with a colleague who is an expert in fluid dynamics and has given us some really good information on aerosol and droplet, and how it's, of course, it's really a continuum, but the various means of transmission and what the relative risks appear to be, and some of the other factors. So that's been really helpful as we deliberate and make decisions on this.
Someone wants you to make a prediction, Dr. Jean. Based on current infection rates, what is the projection to when schools will be open to in-person instruction?
Oh gosh, yeah, that's really tough. It does certainly seem like we're not going to have a lot of in-person instruction, except perhaps in some rural areas and very small schools off the bat this fall. I think it's going to be very interesting to see how the comprehensive distance learning and some of the hybrid models where there is some in-person instruction on limited days for limited groups, how that affects the statewide and county by county transmission rates. So I think we'll have, I'm not sure I can really speculate at this point, but I think, once we get into September and October and see how those things go, and then we'll have a better idea of, when schools might reopen and how much of an effect it's going to have. It's a give and take, because not only does reopening schools to in-person instruction potentially drive a lot of transmission, but we also are responding to transmission because we don't want to reopen and have a lot of kids in school if the community that they're in already has a relatively high rate, as many do right now. So we need to that's why we have these metrics. We need to get below a certain threshold before it's really even worth trying to reopen them. Otherwise, we're just going to see this acceleration of spread.
Yeah, and you can, we don't have actual medical publications on this yet, but in the popular press over the past week or two, you've definitely seen around the country schools reopening and closing within days because of cases. So where is the sweet spot? I think the best data would be yeah, looking at other countries and trying to get to that rate before we try to open schools is trying to get best practices. So there was a person who wanted to see the studies on aerosols and droplets. We'll put that on our list of things to keep an eye on, and if we start to see good published data on that, we'll bring that to a future webinar. I know there's multiple now groups that are doing rapid evidence reviews, tons of stuff out there that's being worked on anyway. So we'll try to keep an eye on that, and if we do see anything that comes across our desks that look pretty concrete, we'll let you know. And then would that change some of our guidance based on I think if we did see aerosol transmission as a main cause, OHA would look at our guidance and see if anything needs to change.
Yeah, and we already have done that to some extent. It doesn't appear that aerosol is responsible for the majority of transmission, but it's responsible for some significant minority of all transmission events. So that's why we've revised about face shields, and it's why we recommend having a good ventilation and doing things outside as much as possible, for example.
Someone asked that they didn't hear my title. I apologize if I said that too quickly. My name is Ariel Smits. I am the medical director of the Health Evidence Review Commission. That is the group that is in charge of the prioritized list, and we kind of set policy for OHA. And I have been acting as an OHA senior health advisor with the COVID emergency. Hopefully, I apologize for skimming over that. I think Tom did a much better job clearly enunciating his job titles. Let's see.
There's a lot of words in our job titles, Dr. Smits.
And we have a lot of job titles at the moment with all of the COVID changes. So I'm looking to see if it looks like that might be the questions that have come in. So we will definitely keep an eye on the aerosol question. I think that's something that's real high on our lists. Anyway, to keep an eye on, we're going to definitely be keeping an eye on the antigen tests as a way to do maybe more rapid and broad screening. So we'll also keep an eye on that. Again, I would refer you to the data dashboard that you see. There is so much information in there, really helpful. And again, there is all of the older presentations, including this one today. Is a little bit later today will be posted on our website.
Yeah, and then just a reminder, so this page that's highlighted there is the main OHA COVID page. Towards the top of that page is, I just wanted to remind, since you are our clinician partners here, there is a yellow box on the right side towards the top of that page that takes you to the healthcare provider specific page. And that has a whole bunch of kind of accordion pop-out menus, and there's a big section for healthcare providers that's got the Remdesivir, it's got our testing guidance, it's got our clinical and infection control guidance that I mentioned earlier, long-term care facilities, etc. So that's a good place to check maybe once a week for updates.
Does the data dashboard have the 7-day count by county, since that's the metric being used for schools?
Yeah, so that's school metrics. The blue box at the bottom, the school metrics is, it has the past 3, actually looks like now it has the past 4 weeks, case rate per 100,000 for statewide and each county. And it also has the test positivity rate for each of those weeks for each county.
Any comments on news recently that there might be a travel ban?
I have not heard anything else other than what's been reported in the news in the past day or two, that the governor's office is contemplating potentially a travel ban, but I'll have to defer to them. I don't know if there's going to be a press conference this week, or I'm actually not privy to that right now, but I know as much as you do on that. We'll have to see.
There was a question about OHA's policies on having childcare inside schools if it's not safe to have school in person.
Yeah, this is an area of active discussion right now. There was just a meeting yesterday on this, and it is a challenge because we have our early learning division guidance, which is quite different from our school guidance for various reasons. They're very different, sectors in one sense, even though they both deal with children. And so, yeah, the question of can there be any kind of before or after school activities or childcare, Head Start, that kind of thing, if a school is closed to in-person instruction? That is a very hot topic right now. So we are, I guess I would just say stay tuned, because we need to try to reconcile that and make sure we can, meet everybody's needs, but while still keeping students and staff safe.
Yeah, and I would have to say that the evidence on child care, daycare, is mixed. New York City did a study of their emergency child care and found almost no transmission. But in Oregon, we've had a couple of different child care center outbreaks. So, that's definitely something that we're keeping an eye on and thinking about. Then there was a question about basically what data do we have on child tolerance for wearing masks?
I haven't personally looked at any data on that. Have you?
One of the other SHAs I know had had been trying to answer that question and pulled some data. So maybe we'll put that on our list of things to look at.
Yeah. Yeah, and I think that's right. I think one of them had looked at some data, and that went into our part of our recommendation to change to the kindergarten and above, which many other states have already recommended. And part of the school guidance, there's a section there that talks about parents working with their kids prior to starting school to kind of get them used to wearing a mask and how to handle that.
And just also advice to give would be, there are many different types of masks, styles of masks. A child might not tolerate one that goes over the ear, for example, and you could get one of the head ties. They might not tolerate a certain fabric or other, so working with your child or the children in your practice, families in your practice, to try different types of materials, different designs of face coverings, until you find one that the children can tolerate.
Yeah, and also in the school guidance is a lot about ensuring that there's adequate breaks from wearing masks. So that would be outdoors, also while eating meals, and of course while you're eating meals you can't wear a mask, but you need to really maintain distance and practice good hand hygiene. So there are a lot of challenges there, but I think it's a successful approach.
Great, thank you. So it sounds like we have a few things to follow up on, and I wanted to just go ahead and maybe we'll give you a few minutes back of your time today. And I wanted to remind you all that next week will be Project Echo. They're the second and fourth Thursdays. So there's the site to register on the slide on the bottom part there. We'll be back in 2 weeks. This is the first Thursday. We'll do the third Thursday. So we'll be alternating with Project Echo. And so please tune in for that. And we will be happy to talk to you all again in a couple weeks. Again, if you have questions and we haven't answered them, or you haven't had a chance to put them in the chat box, feel free to email them, and we will try to see what we can do to address them next week.
Yeah, and thank you all for everything you do, and thanks for tuning in. We'll talk to you next time.
Yeah, thanks for all your work, for all the Oregonians out there.